You are standing in A&E. It's maybe 2 in the morning. You're looking at a 19-year-old who just took a really heavy fall on an outstretched hand.
The absolute classic mechanism.
Right, the absolute classic. The wrist aches, maybe there is a tiny hint of swelling, but you pull up the initial plain radiographs on the screen, and they are completely clear. Every single cortical line looks pristine.
And that is exactly where the trap snaps shut.
It is incredibly tempting to just diagnose a simple sprain, hand them a wrist splint, and discharge them, isn't it? But that clear radiograph is arguably the most dangerous piece of data in the room.
Oh, absolutely, because lurking beneath that seemingly innocuous film might be a fracture capable of ending a manual career or, altering a sporting trajectory entirely.
Or causing lifelong irreversible joint destruction, which is why we're focusing entirely on the scaphoid today, the small bone with extraordinarily big consequences.
Because missing this injury in the acute setting, it commits the patient to a cascade of mechanical and biological failures that are exceedingly difficult to reverse later on.
We are talking about progressive carpal collapse, severe osteoarthritis, and eventually a wrist that simply ceases to function as a dynamic joint. The stakes in that initial consultation could not be higher for you as a clinician.
They really couldn't.
So our mission today is a comprehensive journey through scaphoid fractures. We've tailored this specifically for the orthopedic trainees, trauma surgeons, and emergency physicians managing this pathology on the front lines.
And we're going to cover a lot of ground today.
We are. We will move organically from the diagnostic dilemmas of occult injuries into the intense acute management debates, specifically surrounding the SWIFT trial, all the way through to the dreaded complications of a vascular necrosis and non-union. Welcome to Deep Dive Ortho.
It's great to be here to discuss this. I really understand the scaphoid. We have to view it as the ultimate structural linchpin of the wrist.
Right. Mechanically, it acts as a physical bridge between the proximal and distal carpal rows.
Precisely. When the wrist moves through flexion, extension, and radial or ulnar deviation, the scaphoid is subjected to immense shear and bending forces. It's constantly attempting to coordinate the complex kinematics of the entire carpal mechanism.
The phrase Achilles heel of the wrist gets thrown around constantly.
It does.
And it is mechanically accurate. But the mechanical burden is only half the tragedy here, isn't it? The true vulnerability is biological.
That is the crux of it. Form dictates function, but in the scaphoid, vascularity dictates the ultimate outcome. To understand why we treat these fractures the way we do, we first have to understand why they fail to heal with such alarming frequency.
Because the anatomy of the blood supply here is notoriously peculiar.
It's a nightmare, frankly. The entire problem lies in that vascular anatomy. The scaphoid receives its blood supply primarily from the radial artery, specifically via the dorsal carpal branch.
Right.
But the critical anatomical quirk is the point of entry. The blood vessels do not enter the bone at the proximal end, which sits closest to the radius.
Which you would intuitively expect them to do.
Exactly, but they don't. Instead, they enter distally, predominantly along the dorsal ridge. And from there, the intraosseous vessels have to travel backward, proximally, to supply the rest of the bone.
It is essentially a physiological cul-de-sac.
That is a brilliant way to picture it.
The vascular architecture is entirely retrograde. So if we visualize the blood supply as a single road leading into a narrow neighborhood, the vessels enter at the distal pole, supplying those houses first, and then continue down the street to the proximal pole.
Yes.
If a fracture occurs across the waist or the proximal pole, it acts as a catastrophic roadblock. The distal fragment remains perfectly well perfused because the point of entry is intact.
But the proximal fragment sitting at the end of that severed road is completely isolated. It is instantly starved of perfusion.
Because the fracture line shears those tiny interosseous vessels instantly.
Instantly. And without a robust, continuous blood supply, that proximal fragment is robbed of the cellular machinery required for osteogenesis. The biological environment just becomes profoundly hostile to healing.
The macrophages can't reach the site to clear the necrotic debris.
Right. And mesenchymal stem cells cannot migrate to the fracture gap to differentiate. And crucially, the osteoblasts lack the oxygen and nutrients to actually lay down new woven bone.
And we compound that hypoxic environment with the surrounding anatomy, too. I mean, the scaphoid is almost entirely covered in articular cartilage because it functions somewhat like a universal joint within the wrist.
Yes, which means there is very little exposed cortical bone for surrounding soft tissues to form a vascularized soft callus.
We are relying almost entirely on primary bone healing, creeping substitution from the inside out.
Exactly. And if the synovial fluid, which contains enzymes that actively inhibit clotting, if that fluid washes away the fracture hematoma, that initial scaffolding for bone healing is completely lost.
Which perfectly explains why scaphoid fractures are uniquely plagued by delayed union, non-union, and the devastating reality of a vascular necrosis.
It does. And because the biology is so unforgiving, missing the diagnosis isn't just a minor oversight in a busy trauma clinic. It's a critical failure that directly alters the patient's prognosis.
Which brings us right back to that diagnostic dilemma we face in the acute setting. Let's explore that challenge.
Let's do it.
We have our patient with the clear X-ray but ongoing pain. As clinicians, we rely heavily on our clinical exams. We're taught anatomical snuff box tenderness, scaphoid tubercle compression, and axial loading of the thumb.
We are. But looking closely at the biomechanics of those tests, you quickly see why they lack specificity.
They're incredibly sensitive, though.
Oh, highly sensitive. Anatomical snuff box tenderness has a sensitivity approaching 90%. I mean, if the scaphoid is broken, the snuff box will almost certainly hurt.
But the specificity is remarkably low, sometimes reported down to 40%.
Exactly. And the problem is the dense anatomical neighborhood you're pressing on. Palpating the anatomical snuff box, that depression between the EPL, EPB, and APL tendons, you are compressing multiple structures simultaneously.
You could easily be eliciting pain from a sprained radioscaphoid ligament.
Or a radiocarpal joint effusion. Furthermore, this superficial branch of the radial nerve runs directly across this exact area.
Right. And compressing a normal, healthy nerve against the underlying bone will elicit a pain response in almost anyone.
Absolutely. The scaphoid compression test shares the exact same flaw. Axially loading the first metacarpal drives the trapezium into the distal pole of the scaphoid.
Which in turn drives the proximal pole into the radius.
Right. It tells you something in that mechanical chain is unhappy, but it absolutely did not confirm a cortical breach.
And this diagnostic uncertainty historically led to the dreaded suspected scaphoid pathway. We've all seen it. We've all done it.
The classic fortnight in plaster.
Exactly. We would place the patient in a rigid fiberglass or plaster cast for 10 to 14 days, completely immobilizing the wrist and thumb, and then bring them back to the fracture clinic.
We were essentially waiting for osteoclastic resorption at the fracture site to widen the gap, just hoping the invisible line would finally show up on a repeat plane film.
We were actively waiting for the bone to fail a little bit more so we could see it. It sounds archaic when you say it out loud.
It is archaic. And thankfully, the evidence has aggressively and rightly shifted away from that wait-and-see dogma. Monk and colleagues, among several others, demonstrated the exquisite sensitivity of MRI for occult scaphoid fractures.
An MRI does not wait for bone resorption.
No, it doesn't. By utilizing fluid-sensitive sequences like SDR or T2 fat-suppressed imaging, it visualizes the bone marrow edema instantly. It provides an immediate, definitive answer regarding the presence of a trabecular or cortical injury.
And this shift is reflected in modern national frameworks. For instance, the NICE guidelines in the UK mandate a very clear pathway. If the initial plain radiographs are negative, but clinical suspicion remains high based on those sensitive but nonspecific tests, an MRI within 48 hours is the definitive investigation of choice.
That is the gold standard now.
But realistically, and we have to acknowledge the absolute chaos of a modern trauma system here, if an NHS trust is already fighting for scanner time for stroke patients, oncology staging, and suspected cauda equina syndrome,
I know where you're going with this.
mandating a rapid MRI for potential wrist sprain feels like an administrative impossibility to a lot of clinical directors. It is very easy to argue that the resource allocation simply isn't justified on a busy weekend.
Hospital management frequently raises that exact logistical challenge. I hear it all the time. However, the health economics and the comprehensive cost-benefit analysis overwhelmingly favor the rapid MRI pathway.
Walk us through those economics, because that's the argument clinicians need to take to their management.
Consider the cascading costs of the alternative. If you place every single suspected scaphoid into a cast for 2 weeks, you are immobilizing a largely young, active, working-age demographic.
They can't drive. Manual laborers cannot work.
Exactly. You are consuming massive amounts of plaster room resources, you are booking hundreds of unnecessary follow-up fracture clinic appointments, and taking countless repeat radiographs.
And the reality is that up to 80% of those patients just have a soft tissue injury.
Up to 80%. We have inflicted a significant socioeconomic handicap on them for a fortnight, for absolutely no clinical benefit.
On the flip side, if they do have an occult fracture and the traditional pathway fails them, perhaps they remove the wet cast themselves, or they just don't attend the follow-up clinic, they progress to a non-union.
And the economic burden of a single complex scaphoid non-union reconstruction is astronomical. You are talking about microsurgery, prolonged rehabilitation, and potentially progressing to a salvage wrist fusion.
It completely dwarfs the cost of a routine non-contrast extremity MRI.
Without a doubt. Providing that upfront scan definitively rules the fracture in or out. It discharges the soft tissue injuries immediately and captures the true fractures early. It's better for the patient, and economically, it is vastly better for the system.
So once we have that MRI and it confirms the diagnosis, the treatment algorithm splinters, we cannot treat all scaphoid fractures identically.
Not at all. The anatomical location and the biomechanical stability of the fracture entirely dictate our approach, which brings us to the crucial role of classification systems.
The Roos and the Herbert classifications remain the most clinically relevant frameworks we utilize today. Let's delve into the mechanics of the Roos classification first.
The Roos is fundamentally an anatomical and biomechanical assessment. It's based on the orientation of the fracture line relative to the long axis of the scaphoid.
Right, so it categorizes fractures into horizontal oblique, transverse, and vertical oblique. And this isn't just an academic exercise in geometry, is it? It dictates the physical forces the healing bone will face.
Exactly. A vertical oblique fracture, for example, acts like a sliding fault line. As the wrist moves, the compressive forces of the tarpus translate into massive shear forces across that vertical plane.
Making it inherently unstable and highly prone to displacement.
Yes. Conversely, a transverse fracture orientation means that the natural loading of the wrist actually applies compressive forces across the fracture gap, which is biomechanically highly favorable for primary bone healing.
Building on that biomechanical foundation, the Herbert classification focuses heavily on the broader clinical picture: stability, chronicity, and timing.
The Herbert system is incredibly practical. Type A fractures are stable, acute injuries. Things like an incomplete fracture through the waist or a minor tubercle avulsion.
And then type B encompasses the unstable acute fractures. This includes displaced waist fractures, vertical oblique patterns, and crucially, all proximal pole fractures.
Type C refers to delayed unions, where healing is stalled but the biology may still be viable. And type D represents established non-unions, where the biological process has completely arrested.
Let's focus intensely on the proximal pole, which Herbert categorizes as a type B unstable fracture. This is arguably the most treacherous territory in this entire landscape.
Without question. The clinical pearl here must be unambiguous for anyone listening. Proximal pole fractures carry an extreme risk of a vascular necrosis.
Because of that microscopic retrograde blood supply we detailed earlier.
Precisely. The proximal pole is almost entirely reliant on intraosseous flow that is severed by the injury. Therefore, the standard protocol dictates that surgical fixation is recommended regardless of displacement.
So even if the CT scan shows a completely undisplaced hairline crack through the proximal pole, it mandates a screw.
It absolutely mandates a screw. The biology is simply too fragile to tolerate even a micrometer of movement. Rigid internal fixation is non-negotiable for the proximal pole.
You must achieve absolute stability to facilitate primary osteal reconstruction across the fracture gap.
Yes, because secondary bone healing via callus formation simply will not occur in that ischemic synovial fluid-bathed environment. The surgical intervention is designed to mechanically lock the fragments together so the tenuous biology has the best possible chance of bridging the defect.
But even with a perfectly executed surgical fixation, the biological timeline is brutal. The psychological management of the patient becomes just as critical as the surgery itself.
It really does.
I mean, telling a highly active 25-year-old athlete or a manual worker that they are looking at a minimum 12 to 16-week healing timeline for a bone the size of a cashew, that is an incredibly difficult conversation.
It's one of the hardest conversations in the trauma clinic.
How do you manage those expectations on day one so they don't lose faith in the process? Because at 8 weeks, they're going to want to know why it's not healed.
Transparency from the very first consultation is vital. I clearly state that while they have broken one of the smallest bones in their body, it is undeniably the hardest one to heal.
Do you use the cul-de-sac analogy with them?
I do, actually.
Ah.
I use that exact physiological cul-de-sac analogy to explain their specific vascular anatomy. I ensure they understand that 12 to 16 weeks is not a pessimistic worst-case scenario. It is the fundamental biological baseline for a proximal pole injury.
Preparing them psychologically for the long haul prevents that profound disillusionment at the 8-week mark when they view a follow-up radiograph that still shows a visible fracture line.
Exactly. They need to know that slow healing is the expected trajectory, not a failure of the surgery or their body.
Setting that biological baseline is crucial. So we have established that the proximal pull is a surgical absolute. Now we move into what is arguably the most fiercely debated territory in hand and trauma surgery.
The acute undisplaced waist fracture.
Yes. For decades, surgeons have argued over the optimal management here. Do we place them in a rigid cast for 6 to 8 weeks, accepting the stiffness and inconvenience? Or do we insert a screw percutaneously to allow immediate wrist mobilization?
It's been a massive point of contention, and this intense debate was the genesis of the landmark Swift trial by Dias and colleagues.
The Swift trial was a watershed moment in orthopedics.
It truly was. It was a beautifully designed, multi-center randomized controlled trial, explicitly constructed to compare surgical fixation against cast immobilization for fresh, undisplaced scaphoid waist fractures.
Because prior to this data, there was a massive industry-driven trend toward fixing all of them, wasn't there?
There was a huge push. The prevailing logic was incredibly seductive. The idea was utilize a percutaneous headless compression screw, achieve rigid internal fixation, eliminate the need for a cast entirely, and return the patient to their baseline function weeks earlier.
And the headless compression screw itself is an engineering marvel that made this percutaneous philosophy possible.
Biomechanically, it's brilliant.
The original Herbert and Fisher screw and its modern iterations utilize a differential pitch mechanism. The threads at the leading end, which anchor into the proximal fragment, are spaced wider apart than the threads at the trailing end, which sit in the distal fragment.
Right. And as the surgeon drives the screw fully into the bone, this subtle difference in thread pitch actively pulls the two bone fragments together,
generating immense compression across the fracture gap.
Yes, and furthermore, because the screw is entirely headless, it buries itself deep within the subchondral bone. It sits below the articular cartilage, so it does not gouge the radial articular surface during wrist kinematics.
It sounds like the perfect, elegant solution to this scaphoid problem.
It is a biomechanical triumph, as we said. But the Swift trial humbled the surgical community by looking at the actual biological and functional outcomes.
The trial provided a massive clinical revelation. Percutaneous screw fixation does not change the ultimate union rates for undisplaced waist fractures compared to non-operative casting.
That was the bombshell. When researchers assessed the patients at 52 weeks, the healing rates between the surgical group and the cast group were virtually identical.
So the screw did not biologically accelerate or guarantee union any more than a plaster cast did.
Not at all. However, the trial highlighted a critical divergence in safety. The surgical group suffered a significantly higher complication rate.
We really have to look closely at those complications because they are not trivial. We're talking about deep space infections requiring formal washout.
We are talking about iatrogenic nerve injury, specifically to the delicate superficial branches of the radial nerve during the percutaneous approach, leading to incredibly painful neuromas.
And most troublingly, hardware prominence.
Yes. If that headless screw is not perfectly countersunk beneath the cartilage, which is a really difficult task when operating percutaneously under two-dimensional fluoroscopy, it acts like a piece of titanium grit inside a biological hinge.
It rapidly shreds the radius, causing irreversible radioscaphoid osteoarthritis. Many patients in the surgical arm of the trial required a second formal operation simply to remove the prominent metalwork.
So the synthesis of the Swift data shifts the clinical paradigm entirely. Surgery effectively buys the patient time out of the cast, but it does not buy them superior biology or a guaranteed union.
We're explicitly trading the inherent risks of a surgical procedure for lifestyle and functional convenience. This reality elevates the importance of nuanced, shared decision-making.
It does. It places the decision right back into a discussion about the patient's life, not just their X-ray.
So how do you practically weigh that up with the patient sitting across from you? You have a patient with an undisplaced waist fracture. The bone will likely heal either way, but the paths to get there are vastly different.
I lay out the Swift data explicitly, removing any of my own surgical bias. I explain that cast immobilization is the safest biological route. It entirely avoids the risks of the operating theater, neurovascular injury, and hardware complications, and it is highly likely to result in complete union.
But the cost is 6 to 8 weeks of strict functional limitation.
Exactly. I then individualize the decision based on their socioeconomic reality. Take a self-employed manual worker, an electrician, or a freelance musician. For them, the economic devastation of losing bimanual function for 2 months might far outweigh the surgical risks.
Because if they don't work, they don't eat.
Precisely. For those specific demographics, accepting a 2 to 3% risk of a major surgical complication to shed the cast at week 2 is a highly rational, calculated risk.
Conversely, for a desk-based professional who can manage their workload and typing with a lightweight cast, exposing them to the risks of anesthesia, infection, and potential joint destruction is difficult to justify.
Very difficult. You are treating the patient's socioeconomic ecosystem just as much as you are treating their bony anatomy.
It is a phenomenal framework for navigating the undisplaced waist fracture. But if the undisplaced fracture is a nuanced debate, the displaced fracture is a strict mandate. We must restore the anatomy to prevent rapid and devastating carpal collapse.
There is zero room for debate with a displaced fracture. If the CT scan reveals a step-off in the fracture line of more than 1 millimeter, or if the intrascaphoid angle indicates that the scaphoid has buckled forward into a humpback deformity.
The structural integrity of the entire carpal bridge is compromised.
Completely. If left untreated, the mechanics of the wrist will invariably drive the carpus into a dizzy deformity, a dorsal intercalated segment instability.
The biomechanics of a dizzy deformity are fascinating and highly destructive. Let's bring that down. When the scaphoid fractures and buckles, the mechanical linkage between the proximal and distal carpal rows is broken.
Right, and the capitate, sitting in the distal row, effectively acts like a wedge. It's being driven down into the proximal row by the powerful forces of the forearm musculature.
Without the intact scaphoid to maintain the posture of the wrist, this wedge effect forces the lunate to tilt dramatically backwards dorsally.
While the distal scaphoid fragment flexes forward.
The articular congruity is completely lost.
Yes. And that abnormal load transmission rapidly wears away the cartilage, leading directly to scapholunate advanced collapse, or SLAC wrist, which eventually destroys the entire radiocarpal joint.
So to prevent that inevitable collapse, open reduction and internal fixation is an absolute mandate. This is no longer a minimally invasive percutaneous procedure.
Not at all. The surgeon must fully open the wrist, physically lever the dense bone out of its humpback deformity, frequently utilizing stout K-wires inserted into the fragments as joysticks to manipulate them, restore the normal anatomical length and alignment, and then deploy the headless compression screw under direct vision.
The surgical approach itself is a critical decision here, and the fracture pattern dictates whether you open the front of the wrist or the back.
And once again, this decision is entirely subservient to the biological vulnerability of the scaphoid. We are desperately trying to avoid inflicting further iatrogenic damage to that delicate retrograde blood supply.
Because the dorsal approach involves dissecting straight through the primary vascular territory where the main vessels enter the distal pole.
Exactly. Therefore, for the vast majority of waist fractures, the volar approach is strongly preferred.
The volar approach is biologically protective. The surgeon creates an incision directly over the flexor carpi radialis tendon.
By retracting the FCR tendon ulnarly and carefully protecting the radial artery radially, you access the wrist capsule.
Once the capsule is incised, the scaphoid tuberosity is beautifully exposed, and this entire trajectory completely spares that crucial dorsal blood supply.
It does. And from this volar vantage point, you can perfectly align your guide wire and place the compression screw down the central longitudinal axis of the bone from distal to proximal, achieving maximum biomechanical purchase.
However, the volar approach is physically impossible for proximal pole fractures.
It is physically impossible.
The proximal pole is a tiny, curved, cartilage-covered fragment hidden deep within the dorsal aspect of the radiocarpal joint.
Trying to accurately target that fragment with a drill and a screw from the volar side is anatomically akin to trying to shoot a tiny target around a sharp corner while blindfolded.
You will invariably miss the central axis or, worse, blow out the side of the cortex.
Exactly. For proximal pole fractures, you are forced to utilize a dorsal approach. You must open the back of the wrist, look directly at the proximal pole, accept the inherent, unavoidable risk to the local vascularity, and place your screw from proximal to distal.
It highlights the brutal paradox of proximal pole fractures. The injury itself starves the bone of blood, yet the only surgical approach capable of mechanically fixing the fracture inherently threatens whatever microscopic collateral blood supply might remain.
It is a relentless balancing act between biomechanical necessity and biological preservation.
So what happens when, despite our best efforts, the biology simply fails? Perhaps the initial cast immobilization didn't work, or the percutaneous fixation failed to achieve union?
It happens. The patient presents to the clinic 6 or 9 months down the line with an ongoing, deep-seated ache in the anatomical snuff box.
You pull up a new radiograph, and instead of bridging trabeculae, there is a clear sclerotic gap. The scaphoid has progressed to an established non-union, or worse, a vascular necrosis has set in.
At this point, the surgeon enters salvage mode,
Yeah.
and the complexity of the problem scales exponentially.
Entering salvage mode requires a complete reassessment of the biological landscape. The absolute first critical step is definitively diagnosing the presence or absence of a vascular necrosis.
Because if the proximal pole is dead, your entire surgical reconstruction strategy must change. Standard bone grafting will fail.
Diagnosing AVN definitively is notoriously difficult. We rely heavily on preoperative imaging, but scans have significant limitations.
They do. High-resolution MRI is excellent, particularly when utilizing gadolinium contrast enhancement. A lack of contrast uptake in the proximal pole strongly suggests profound ischemia and probable AVN.
Fine-cut CT scans are unparalleled for defining the three-dimensional bony architecture, measuring the exact volume of the cystic bone loss, and planning the graft size.
But the true, undeniable gold standard for diagnosing AVN remains intraoperative direct visualization.
Imaging gives us a probability, but the operating theater gives us the truth.
Exactly. Under a pneumatic tourniquet, the surgeon meticulously opens the fracture site. You must meticulously curette and debride all the fibrous, interposed non-union tissue, and the sclerotic bone ends until you reach what looks like healthy architecture.
Then you explicitly drop the tourniquet pressure to 0.
Yes. You observe the bone ends directly. You're looking for punctate bleeding. If the cancellous bone slowly oozes bright red blood, the bone is biologically alive. It has simply failed mechanically and needs structural support.
If, however, the proximal pole remains completely stark white, hard, and bloodless, resembling a piece of dry chalk, the bone is definitively dead. You have visually confirmed a vascular necrosis.
And that visual confirmation entirely dictates your choice of bone graft. Let's compare the reconstructive frameworks. If the tourniquet drops and you see that beautiful punctate bleeding, the bone is alive. There is no AVN. What is the standard structural option?
If the biological environment is viable, you can confidently utilize a non-vascularized bone graft.
Right. The surgeon harvests a solid block of corticocancellous bone, typically from the distal radius or the iliac crest, shapes it to perfectly match the defect, and packs it tightly into the non-union site.
This restores the normal scaphoid length and corrects any humpback deformity. And because the surrounding host scaphoid bone is alive and perfused, creeping substitution will slowly occur.
The host osteoclasts will resorb the dead graft, and host osteoblasts will lay down new, living bone, eventually incorporating the graft into a solid union.
But if the tourniquet drops and the proximal pole is a piece of dead white chalk,
Packing a dead, non-vascularized piece of iliac crest against a dead avascular proximal pole is biologically futile. It is a guaranteed failure.
you cannot expect creeping substitution when there is no blood supply to drive the cellular engines. You need to actively bring a new independent blood supply into the ischemic zone.
This is the domain of the vascularized bone graft, and the classic workhorse for this is the 12-Bong2 ICSRA pedicled graft, originally described by Zadenberg.
The 12-2 ICSRA, or the intercompartmental supraretinacular artery graft, it is a masterclass in orthopedic microsurgery.
It really is. The surgeon must meticulously dissect the dorsal aspect of the distal radius to locate this tiny, fragile artery that runs longitudinally between the first and second extensor compartments.
Once identified, you use a fine saw or osteotomes to harvest a small block of the underlying radial bone, critically keeping that tiny artery and its associated draining veins completely intact.
Attached to the bone block is a vascular pedicle.
It is essentially an organ transplant on a microscopic scale. A non-vascularized graft is like cutting a branch off a tree and sticking it in dry dirt, hoping it miraculously takes root.
Whereas a vascularized 1-for-2 ICSRA graft is like transplanting a small tree with its entire root ball and surrounding soil completely intact.
Because the original injury created an insurmountable roadblock to perfusion, this graft physically builds a living vascular bypass over the wreckage, delivering a fresh, pulsing blood supply directly to the starving proximal pole.
That root ball analogy captures the biological intent perfectly. You are physically swinging a living, actively bleeding block of bone on its vascular tether into the scaphoid defect.
However, patient selection and surgical precision are paramount here. It is a highly demanding procedure.
One slightly aggressive pull with a retractor or a momentary lapse in focus can instantly avulse or thrombose that microscopic pedicle. In a millisecond, your highly complex vascularized graft reverts to a standard non-vascularized graft.
But when executed flawlessly in a younger patient facing the devastating prospect of an avascular proximal pull, it remains a limb-saving procedure capable of reversing the biological clock.
The microsurgical skill required is staggering, but the results can be remarkable.
Now, throughout this discussion, we have established the strict, unyielding biological rules of scaphoid healing. We know it takes a minimum of 12 to 16 weeks for proximal pull injuries to unite. We know the devastating consequences of mechanical instability.
Yes.
But what happens when those slow biological rules collide head-on with the high-stakes, hyper-accelerated demands of an elite sports season? Let us examine the unique challenges of the athlete scaphoid.
Managing the elite athlete introduces profound socioeconomic and psychological pressures that completely warp the standard clinical algorithms.
When managing a professional footballer, a premiership rugby player, or an Olympic gymnast, you cannot simply hand them a cast and tell them their season is over for 4 months.
You'd be laughed out of the training room. The standard Swift trial logic, which heavily favors cast immobilization for undisplaced fractures, is often abandoned entirely in this cohort. The algorithm shifts aggressively towards prophylactic percutaneous surgical fixation.
And the goal isn't necessarily to heal the bone faster, because biology still dictates the cellular timeline, but rather to provide internal mechanical splinting.
By inserting a rigid headless compression screw, you eliminate the micromotion at the fracture site.
This internal stability may allow the athlete to return to modified training, cardiovascular conditioning, or even competitive play significantly earlier than cast immobilization would permit, often augmented by a specialized playing cast.
Exactly. You are substituting external plaster stability with internal titanium stability. However, this creates an incredibly perilous clinical dynamic. Biology remains entirely indifferent to the cup final or the Olympic trials.
How do you protect the hypermotivated athlete from themselves? Their manager is pressuring the medical staff. The player feels physically fine because the screw has eliminated the mechanical pain, but the bone has not biologically bridged.
That's the danger zone. If they take a massive high-velocity impact on a structurally unhealed scaphoid, the tremendous forces will simply shatter the fragile healing bone around the rigid titanium screw,
Transforming a simple, manageable waist fracture into a catastrophic, potentially unsalvageable disaster.
You need a watertight objective framework to resist that pressure, because subjective clinical exams are absolutely useless when the bone is internally fixed.
You cannot rely on plain radiographs to determine when it is truly safe for a rugby player to return to unprotected tackling.
The superimposition of the carpal bones and the artifact from the metal screw make plain films woefully inadequate for judging subtle trabecular healing.
We rely entirely on high-resolution, fine-cut computed tomography to clear an athlete for unprotected contact.
I scrutinize the CT scans, specifically looking for definitive trabecular bridging. I need to see continuous mature bone trabeculae crossing the fracture gap across at least 50% of the total cross-sectional area of the scaphoid in both the sagittal and coronal planes.
Until that 50% biological threshold is definitively visualized, the athlete does not return to unprotected impact sports.
You do not. Now, if their specific sporting body allows a rigid or semi-rigid silicone playing cast, we might negotiate an earlier return to the pitch, but the regulations vary wildly.
A rugby referee will absolutely prohibit a hard cast, whereas a footballer might be permitted to play with a soft, padded silicone splint.
In these scenarios, you're managing the complex interplay between bone biology, biomechanical load, and the legal rulebook of the sport.
It is a high-wire act balancing orthopedic science with elite sports administration. We have covered an immense expanse of clinical territory today, from the microscopic anatomy of intraosseous blood flow to the macroscopic biomechanics of carpal collapse.
It's a complex bone.
Let me distill the most vital, practice-changing frameworks for our listeners to take back to the trauma clinic tomorrow. First, the diagnostic imperative, the 48-hour MRI pathway. If you are examining a patient with a clinically suspicious wrist but a pristine X-ray, do not condemn them to the historical 2-week plaster cast pathway.
Fight for the MRI within 48 hours.
The health economic data and the prevention of catastrophic non-unions make it the definitive, cost-effective investigation of choice. Second, the absolute anatomical rule. Proximal pull fractures carry an extreme inherent risk of avascular necrosis due to their reliance on retrograde blood supply.
Surgical fixation to achieve absolute stability is recommended regardless of the degree of displacement.
Furthermore, you must transparently prepare these patients for the brutal reality of a 12 to 16-week biological healing timeline. Third, the profound reality check from the SWIFT trial. For acute, undisplaced scaphoid waist fractures, percutaneous headless compression screws offer the convenience of early mobility, but they provide absolutely no superiority in final union rates compared to cast immobilization.
while carrying significant surgical risks. This requires nuanced, individualized, shared decision-making based on the patient's socioeconomic needs.
If clinicians firmly grasp those three foundational concepts, they will navigate the vast majority of the pitfalls associated with scaphoid trauma.
Absolutely.
Before we conclude, we have spent this entire session discussing how to react to the biology of a fracture once it has occurred. We apply casts, we insert screws, and we wait to see if the bone responds. But looking forward, the true paradigm shift won't just be mechanical, it will be predictive.
Oh, the predictive models are going to change everything.
With the rapid evolution of high-resolution multi-parametric MRI, advanced perfusion modeling, and machine learning, we're approaching a horizon where we won't just guess who will heal. Imagine an AI algorithm analyzing the microvascular flow and trabecular density on the day one injury scan.
Explicitly predicting. This specific undisplaced fracture lacks the localized perfusion to heal in a cast and will progress to non-union. Operate now.
This would transition us from playing the statistical odds of the SWIFT trial to delivering truly personalized, preventative orthopedic trauma care.
The predictive horizon is phenomenal. Once we can reliably map microtrabecular density and merge it with patient-specific perfusion modeling on day one, the entire reactionary treatment algorithm we rely on today will be completely rewritten. We will treat the biological potential of the fracture before it ever has the chance to fail.
A brilliant perspective to end on. If this deep dive added structural value to your clinical practice today, please take a brief moment to rate and share the show with your colleagues to help us keep bringing these high-level discussions directly to you. We began this discussion reflecting on the comforting, engineering-like precision of a standard orthopedic X-ray and how the scaphoid shatters that illusion. Hopefully today we have brought some clarity to those diagnostic and biomechanical muddy waters, providing you with the exact frameworks needed to navigate the hidden disasters of the wrist. Thank you for listening.